Hi, I'm Megan Broderick, a fourth-year resident at Stanford Hospital. I would like to thank the Connecticut chapter of the American College of Surgeons for giving me the opportunity to discuss my research. Today, I will be presenting on the utility of mandatory repeat head CTs in detecting delayed intracranial hemorrhage in patients on novel oral anticoagulants who have sustained head trauma after falls from standing. As the American population gets older, geriatric trauma has become increasingly common. Falls are the most common mechanism of injury for people over 65, followed by motor vehicle collisions. According to the CDC, 27.5% of adults 65 years or older reported at least one fall during the previous year, and 10.2% of this population reported an injury related to a fall, amounting to 8.4 million fall-related injuries in 2018 alone. One of the most feared complications of falls in the elderly is intracranial hemorrhage, and this is of special concern in patients taking anticoagulation who have a twofold increase in risk of intracranial injury after blunt head trauma when compared to patients who are not anticoagulated. There has been significant attention paid to the rates of delayed hemorrhage amongst this patient group, but no consensus has been reached regarding how best to monitor for delayed hemorrhage, which has been observed at a rate of 0.6 to 6% in various studies. Data is especially limited concerning patients taking novel oral anticoagulants, dabigatran, rivaroxaban, and apixaban, as much of the previously published data does not differentiate between warfarin and NOACs when determining patient outcomes. As more and more patients are being prescribed NOACs in place of warfarin, we extrapolated our policy regarding these drugs from our warfarin data, as it was unclear if there would be a difference in rates of delayed intracranial hemorrhage on these medications. Our current practice is to admit patients for repeat head CT if they are on a NOAC or if they are on warfarin with an INR greater than or equal to 2. This protocol was put into place after we had 4 patients develop delayed intracranial hemorrhage while taking warfarin with an INR greater than or equal to 2 on presentation. As we had previously presented, a review of the first 50 patients presenting to our institution on NOACs had no evidence of delayed intracranial hemorrhage. The purpose of this study is to determine incidence of delayed intracranial hemorrhage in a larger group of patients and to determine if a change to our current protocol would be feasible. We hypothesized that, unlike our institutional experience with warfarin, we would not find any instances of delayed intracranial hemorrhage in neurologically intact patients taking novel oral anticoagulants after head trauma related to a fall. This finding would be significant as it would allow us to change our protocol for these patients and discharge them after a period of observation from the emergency department rather than admitting them for repeat head CT. We conducted a retrospective review of trauma evaluations for falls on NOACs from January 2016 through December 2018. Patients were excluded if they had positive traumatic findings on their initial head CT, presented with new neurologic deficits or GCS less than 14, or were taking antiplatelet agents or other anticoagulants in addition to NOACs. 159 patients were included in our review. Patients ranged in age from 19 to 98, and almost all of our patients were greater than 60 years old. 37% of the included patients were male and 63% were female. The most commonly used medication was apixaban, being prescribed to just over half of the patients. 94% of patients had an initial GCS of 15, with the remaining 10 patients having a GCS of 14. 12 of the patients presented greater than 6 hours after their fall, and as such, had only one head CT. No cases of delayed intracranial hemorrhage were identified in our study population. In summary, a review of over 200 patients taking NOACs at our institution failed to show evidence of delayed intracranial hemorrhage after ground-level falls when patients were neurologically intact with negative imaging on presentation. This supports a growing body of literature that questions the necessity of obtaining delayed imaging in this patient population. Given the large number of patients who present to emergency departments across the country with this mechanism of injury, eliminating routine delayed imaging represents a potential area of tremendous cost savings for the healthcare system. Currently, our institution is in the process of enacting a policy change reflective of our results. These are my references. I would like to thank the Connecticut chapter of the American College of Surgeons for this opportunity and will now answer any questions you may have. Thank you.